We are all just completely obsessed with the after photo.
Right.
You know, like you scroll through social media or look at a clinic's website, and all you see is that glossy, perfect final result.
Oh, absolutely. The skin is glowing. The surgical outcome is flawless. It just looks effortless.
Right, effortless. But today, for this deep dive, we are going through a massive stack of medical protocols to look at the before. And I don't mean the before photo. I mean the intense, like, weeks-long biological and mental preparation required before aesthetic and intimate procedures even begin.
Yeah, and that preparation phase is, well, it's entirely invisible to the public eye. Yet, as our source today reveal, it is, without a doubt, the single most critical factor in determining whether an intervention is a success or, a severe medical complication.
Exactly. And we're looking at a huge spectrum of treatments today. We pulled from clinical guidelines on everything from transvaginal laser therapies and surgical labiaplasties to breast lipomodeling and facial injectables using purified salmon DNA.
Which I know sounds totally wild to hear.
Right. If you're hearing salmon DNA and thinking we've crossed into science fiction, stick around because we're definitely going to break down exactly what a polynucleotide is. But our main mission today is to unpack why these pre-treatment rules actually exist. I like to think of it like painting a room in your house.
Oh, that's a great analogy.
Yeah, like you can't just crack open a can of paint and slap it on the wall. If you actually want it to look good, you spend days doing all that invisible work.
Yeah.
Taping the edges, laying down drop cloths, stripping the old wallpaper.
Yeah, and if you skip the prep work, the final result is just a total disaster.
A mess, yeah.
But, the human body is infinitely more complex than a living room wall. I mean, you are dealing with active immune systems, shifting blood chemistry, and psychological states. So before anyone even touches a needle or a scalpel, the preparation really has to start in the mind and in the paperwork.
Right. And I notice this heavily in the sources regarding permanent surgical procedures.
Right.
Specifically things like labiaplasty, which is the reduction or reshaping of the labia minora, and vaginoplasty, which addresses vaginal laxity. The protocols state that the very first step is actually a diagnostic triage with a general practitioner.
Exactly. The clinician's initial job is to determine the root cause of the patient's distress. They need to figure out, is there a genuine functional or medical problem here?
Like tissue damage from childbirth or something.
Right, or perhaps an underlying dermatological condition. For example, lichen sclerosis, which causes severe inflammation and requires medical management rather than surgery. They have to separate those functional issues from, well, purely aesthetic concerns.
And the guidelines are pretty clear that the NHS, for instance, rarely funds these surgeries for cosmetic reasons alone. They require severe physical trauma or significant congenital malformations. But what I found so fascinating in the prep protocols from bodies like BAPAS, that's the British Association of Aesthetic Plastic Surgeons, is the really heavy emphasis on psychological evaluation.
Yeah, patients are often advised to speak to a counselor before even committing.
Which, okay, at first glance, if someone is experiencing physical discomfort, like while cycling or wearing tight clothing, sending them to a phycologist seems almost, I don't know, dismissive of their physical pain. But then looking at the data on patient motivations, it starts to make a lot of sense.
It really does. The data paints a very clear picture of just a widespread lack of awareness about female anatomy. I mean, the range of what constitutes a normal genital appearance is incredibly vast.
It's huge, yeah.
Yet studies show that the rising number of women and young girls requesting labiaplasties are often driven by the skewed perception that their external anatomy is somehow abnormal.
Because they're comparing themselves to, like, highly curated, surgically altered, or digitally modified explicit images online.
Exactly. So the clinician has to figure out, are they sanding down a solid foundation, or are they trying to fix a structural issue with cosmetic paint? And a psychologist helps untangle that. Satisfaction with cosmetic outcomes is highly subjective,
Right, if you're trying to fix a mental pressure with a physical surgery.
It rarely works. If a patient is seeking an irreversible surgery to relieve a temporary social pressure, or if they're suffering from body dysmorphic disorder, changing the physical anatomy rarely cures the psychological distress. The mental preparation ensures the patient has grounded, realistic expectations about what the surgery can actually achieve.
And part of grounding those expectations is the paperwork prep, which sort of shifts the patient from being a passive consumer into an active participant. You can't just do a quick internet search for a doctor. In England, the protocols require checking the Care Quality Commission, or CQC.
Yeah, and you have to verify the General Medical Council Specialist Register to ensure the surgeon actually has a license for that specific specialty.
Right. You also want to look for active memberships in professional bodies,
Hmm.
like BAPRAS, the British Association of Plastic Reconstruction, and aesthetic surgeons. But honestly, the most crucial part of this administrative prep is formulating your questions. The sources outline that patients must ask about specific complication rates, like the exact number of these specific procedures the surgeon has performed, and the detailed follow-up protocols if something goes wrong.
Yeah, and once that mental foundation is solid and the surgeon is vetted and the procedure is officially booked, the nature of the preparation shifts dramatically. You move from the administrative checklist into what we can call the biological countdown.
Oh, this part blew my mind. Your body actually has to become a completely different environment.
It does. The focus turns inward, really aiming to create the absolute optimal biological conditions for healing. And the timeline typically starts about 2 weeks out from the procedure.
Which is where the rules get incredibly strict. So at 2 weeks to 24 hours prior, patients are given a list of supplements they must absolutely stop taking. And the sources highlight vitamin E, fish oils, so your omega-3s ginkgo biloba, St. John's wort, and vitamin C.
And then at the 1 week mark, you have to discontinue over-the-counter medications like aspirin and ibuprofen.
Right, and at 48 hours, you have to completely avoid alcohol.
Those restrictions often surprise patients, to be honest.
I was definitely surprised. I mean, supplements like high-dose vitamin C and fish oil are universally praised for longevity and immune support. People take them religiously. I really had to think about the mechanism here. The only reason to stop something that healthy is if it fundamentally alters your blood chemistry in a way that interferes with the treatment. So I'm guessing this has to do with blood thinning.
You hit the nail on the head. Those supplements are undeniably healthy for daily cardiovascular function, primarily because they act as vasodilators or mild blood thinners.
Meaning they open up the vessels.
Exactly. They widen blood vessels, increase blood flow, and prevent clotting.
Which is fantastic for your heart, but an absolute nightmare if someone is about to puncture your skin 100 times.
Right. Think about the mechanics of treatments like the O shot for intimate wellness or under-eye injectables. These procedures utilize dozens, sometimes hundreds, of microinjections with very fine needles. When your blood is artificially thinned by daily high doses of omega-3s, every single one of those tiny punctures turns into a microhemorrhage.
Oh, wow. So you're turning a standard pinprick into a severe bruise.
It goes way beyond just looking bruised, too. Excessive bleeding creates a compromised healing environment. If the tissue is flooded with blood and severe inflammation, the regenerative products the clinician is trying to inject get washed out. They just cannot bind to the tissue effectively.
That makes total sense.
The core lesson here is that healthy for everyday living does not equal healthy for a medical intervention. We need to control the body's inflammatory response, not amplify it.
And the idea of products needing to bind to the tissue brings us perfectly to polynucleotides and this critical rule of hydration. Let's break down what a polynucleotide actually is because the sources mention purified trout or salmon DNA.
Yes, so polynucleotides are highly purified chains of DNA fragments. They are typically extracted from the sperm of trout or salmon because, biologically speaking, their DNA structure is remarkably compatible with human tissue.
Wait, really? Salmon sperm.
I know, it sounds a bit out there, but they function as these incredibly powerful biostimulators.
So they act like little messengers, right?
Yeah.
They signal your skin's fibroblasts, which are essentially the microscopic factories in your skin that pump out structural proteins, to start producing fresh collagen and elastin.
They do, and they are injected directly into the dermis, which is the deep, active layer of the skin where all that cellular machinery lives. But the mechanism by which these DNA fragments work relies entirely on water. Once injected, the polynucleotides attract and bind to surrounding water molecules. This binding action is what creates the immediate tissue firming, lifting, and deep hydration effect.
Which means if you show up to your appointment chronically dehydrated, you've essentially starved the treatment.
Yeah.
The salmon DNA has absolutely no raw material to bind to.
Exactly.
So when the clinic tells you to drink plenty of water in the days leading up to the procedure, they aren't just giving you like generic wellness advice. They are literally demanding you provide the biological fuel for the treatment to work.
Yes, you are actively priming the cellular environment. The same goes for the instruction to eat a light meal before the session to keep your blood sugar stable. The body needs to be in a state of calm homeostasis.
Okay, so we're 2 days out. The blood chemistry is normalized. The cells are fully hydrated. We are now at the 72-hour to 48-hour window. The preparation moves outward from the internal blood vessels to the external canvas, the surface of the skin.
And this phase introduces incredibly strict protocols regarding topical treatments and any form of physical irritation.
Yeah, for facial procedures, at 72 hours out, you have to pause all active skincare. No retinoids, no AHAs or BHAs, no harsh exfoliants. You have to avoid facial waxing, threading, and even vigorous facial massages. But where it gets really intense is the prep for transvaginal lasers.
Oh, the laser trials.
Yeah, the sources detail clinical trials for lasers treating conditions like genitourinary syndrome of menopause. Patients in these trials were mandated to stop using all vaginal preparations, moisturizers, and lubricants a full 30 days prior to the laser treatment.
A 30-day pause requires immense commitment from the patient, especially if those lubricants were providing daily comfort.
Right, and it sounds even more brutal when we look at the protocols for lichen sclerosis. We touched on it earlier. It's that chronic inflammatory skin condition that causes intense itching, fragile skin, and painful white patches on the genitals.
It's very painful, yes.
And the standard medical relief is a high-potency topical steroid cream. Yet, if a patient is scheduled for a Monalisa Touch CO2 laser treatment to help regenerate that tissue, they must completely stop using their prescribed steroid creams 1 week before the procedure and 1 week after.
Which is tough.
I mean, taking away someone's prescribed medical relief when they are actively suffering seems incredibly harsh. It has to be, because the steroid chemically blocks the laser from doing its job, right?
Exactly. It fundamentally interferes with the physics and the biology of the treatment. Lasers, whether we are talking about a fractional CO2 laser or an erbium-YAG laser, operate on the principle of controlled trauma. The laser beam penetrates the tissue and creates microscopic columns of thermal injury.
So it's intentionally punching thousands of microscopic hot holes into the tissue.
Yes. The body detects those tiny thermal injuries and immediately mounts a natural inflammatory healing cascade. It rushes blood to the area, wakes up those fibroblast factories we mentioned, and forces the tissue to turn over cells and build fresh, healthy collagen.
Oh, I see.
The entire therapy relies on provoking the immune system.
And steroid creams are designed to do the exact opposite. They are immunosuppressants. They artificially calm the skin and shut down inflammation.
Right. So if the tissue is saturated with active steroid medication, you are chemically suppressing the very inflammatory response the laser is trying to provoke. The body cannot mount a robust healing cascade if the localized immune system is turned off. You effectively cancel out the thousands of dollars you just spent on a medical laser.
Wow. Okay, that perfectly explains the steroids. But what about the 30-day ban on moisturizers and lubricants for the vaginal laser trials? If a lubricant isn't a steroid, why is it banned for a full month?
That really comes down to the physics of light and energy. External chemicals, artificial moisture, or thick barrier creams like petroleum jelly physically coat the mucosa, and this artificial layer interferes with the laser beam's optical precision.
Oh, because it blocks the light.
Kinda. When the light energy hits a layer of thick ointment, it scatters.
It turns a highly precise medical instrument into an unpredictable heat spread.
Exactly. The depth of penetration becomes erratic. The clinician needs the tissue to be in its absolute baseline naked state. The laser energy must interact directly with the cellular water, not with a layer of synthetic moisturizer.
Man, it goes right back to stripping the wallpaper.
Yeah.
You can't assess or repair a wall if it's covered in gunk. And speaking of the external canvas, we have to talk about hair removal. There's a very specific protocol for this, especially for intimate procedures, which I like to call the Goldilocks rule.
The Goldilocks rule captures the biological tightrope patients have to walk perfectly.
The sources state that for intimate laser or injectable procedures, patients must shave the treatment area exactly 2 days prior to the appointment. The hair needs to be short or completely absent so it doesn't physically obstruct the treatment, but it absolutely cannot be freshly shaved on the day of the procedure.
Right.
And waxing or depilatory creams are strictly forbidden. I'm assuming this goes back to the idea of controlled trauma. I mean, shaving isn't just cutting hair, it's dragging a sharp blade across the skin.
Exactly. Whenever you shave, especially in sensitive anatomical areas, the razor drags across the epidermis, so the outermost protective layer of the skin. It strips away top layers of cells and inevitably creates microtears. Even if you can't see them with the naked eye, the skin is temporarily inflamed, irritated, and its barrier function is compromised.
So it's an active microscopic trauma site.
It is. So if a clinician applies a potent chemical numbing cream, or fires a high-energy thermal laser, or administers deep injections into skin that was scraped by a razor an hour ago, the risk profile changes drastically.
Because it absorbs differently.
Yeah, the numbing cream can seep into those micro tears, causing chemical burns or systemic toxicity. The laser can cause severe surface burns because the protective epidermis is missing. Waiting 48 hours allows those microscopic cuts to seal while keeping the hair short enough not to trap bacteria or block the clinician's view.
Not too long, not too freshly shaved.
Exactly.
So we've stripped away the active skincare, we've paused the steroids, we've navigated the Goldilocks shave, and we've thinned out our blood chemistry. The biological countdown has finally reached 0. We are at the day of logistics. And let me tell you, if anyone thought these high-end aesthetic clinics were all champagne and luxury, the actual packing list brings you right back down to earth.
Oh, absolutely. The day of instructions are highly specific, deeply practical, and, well, completely devoid of glamour.
First, there is the scheduling prep. Intimate procedures must be rescheduled if the patient is on their period or if it will start straight after the procedure. Then there is the wardrobe. For intimate injections, like a G-shot, patients are explicitly told to bring and wear white cotton underwear.
Yep.
For breast lipomodeling, which involves harvesting fat from one part of the body via liposuction and transferring it to the breasts, patients must buy and wear supportive high briefs or control underwear that covers the lower abdomen.
You also must arrive with completely clean skin. No makeup, no eye makeup, no lotions, no serums. You leave all body piercings at home or bring a safe place to store them.
And the kicker. You are explicitly told to bring your reading glasses. The ultimate high-tech medical packing list is granny panties, a bare face, no jewelry, and your reading glasses.
It really is.
But, applying the biological logic we've been using, I can totally deduce why the white cotton is mandatory. After microinjections or lasers, the tissue is vulnerable and inflamed. Synthetic fabrics trap heat and moisture, which is just a breeding ground for bacteria. Cotton is breathable. And I'm guessing the color white is specified to avoid harsh synthetic dyes leaching into the fresh microwounds.
Your deduction is spot on. Breathable, undyed fabric actively prevents post-procedure fungal or bacterial infections. It is literally a passive form of wound care.
And the high-control briefs for the breast lipomodeling.
While lipomodeling requires extracting fat, often from the lower abdomen or flanks, the high-waisted control underwear acts as immediate, critical compression therapy for that donor site.
Oh, to keep the swelling down.
Exactly. Compression reduces postoperative swelling, minimizes the risk of hematomas, and physically supports the traumatized tissue as the patient travels home.
I really appreciate the inclusion of the reading glasses on the checklist, too. It highlights the ethical and legal reality of these procedures. They carry genuine risks, potential complications, and unpredictable side effects.
Informed consent is the bedrock of medical ethics. Clinics want to ensure that the patient can physically read, comprehend, and sign the multi-page consent documents. Glossing over the fine print, because the font is too small, is dangerous for the patient's autonomy and a massive liability for the clinic.
You can't just nod along. You have to understand exactly what biological processes you were agreeing to. Now, when you finally get into the clinic room, there are still a few final prep steps. The topical numbing cream, like EMLA or lidocaine, is applied for 10 to 30 minutes, depending on the depth of the treatment. The area is cleaned with a medical disinfectant solution and dried with a swab.
But there is one final, critical piece of medical disclosure that has to happen long before you sit in that chair. The sources emphasize the history of the herpes simplex virus, commonly known as cold sores.
Oh, right.
If a patient has a history of cold sores, they must disclose this well before the day of treatment so the clinician can prescribe preventative antiviral medication.
Because the virus hides in the body, right? It's not always active.
Exactly. The herpes simplex virus lies dormant in the nerve ganglia, which you can think of as the deep root system of your facial nerves. It sleeps there quietly. However, facial procedures, whether it's dozens of polynucleotide injections around the mouth or the thermal heat of a laser resurfacing treatment, cause massive local trauma and inflammation.
And that trauma acts as an alarm bell for the virus.
It is a massive trigger. The virus wakes up and travels down the nerve pathways to the surface of the skin. If a patient does not take prophylactic antiviral medication starting a few days before the procedure, a regenerative skin treatment could easily trigger a severe, widespread viral outbreak across the entirely newly traumatized face.
Wow. Yeah, disclosing that history allows the clinician to control that variable.
It really is all about engineering the perfect, predictable environment for the body to heal. If we look back at the journey we've just outlined, it is staggering. how much active work is required before the actual treatment begins.
It is. It really challenges the traditional dynamic we imagine when we think of a medical procedure.
It totally does. You start by mentally preparing and heavily vetting the surgeon's credentials and complication rates, recognizing that your idea of what is anatomically normal might be entirely skewed by social media. Then you actively alter your blood's chemistry by pausing daily healthy supplements like omega-3s and vitamin C to prevent your blood from thinning and causing microhemorrhages.
You prime your cellular environment by hydrating, so the salmon DNA actually has water molecules to bind to. You carefully time your hair removal to avoid an active epidermal trauma site. You strip away your protective skincare and even your prescribed steroids, so the laser energy can physically interact with your cells. And finally, you arrive barefaced in breathable cotton, ready to read the fine print.
Preparation is undeniably the vital first phase of the medical intervention itself.
Which leaves us with a fascinating shift in perspective to mull over. We usually think of a patient as a passive canvas, like you lie back and an active doctor performs a treatment on you.
Right, that's the standard assumption.
But considering the intense biological, physical, and administrative preparation we've just explored, from intentionally manipulating blood flow to priming cellular hydration, we might have that dynamic entirely backward.
We might. Given the sheer physiological shift required, the patient is actually the one initiating the biological treatment weeks before they even step foot in the clinic. By changing their diet, pausing their medications, and stripping their skin barrier, the patient is doing the heavy lifting of altering the body's internal environment.
Yeah.
The clinician is just providing the final catalyst. They're just rolling the paint on the walls. Because if you, the patient, didn't tape the edges, lay down the drop cloths, and strip the wallpaper for 2 weeks beforehand, well, the whole thing would be a biological disaster. I mean, the prep really is the procedure.